Looks like a man walking. Left atrial enlargement. 371. Left ventricle. The leaflets of the mitral valve are connected to the papillary muscles via cord-like tendons called chordae tendineae. The tendons called chordae tendineae. The papillary muscles insert into the lateral and posterior walls as well as the apex of the left ventricle, not the septum, as is the case on the right. Echogenic focus in left ventricle, relatively common sonographic observation seen on prenatal ultrasound. It is a calcified papillary muscle that usually goes away by the third trimester. So who gives a shit? Well, they are associated with an increased incidence of Downs, 13%. Don't get it twisted, having one means nothing other than you should look for other signs of Downs, most of the time it's normal. Echogenic focus in left ventricle. Lipomatous hypertrophy of the intra-atrial septum. This has a very classic look of a dumbbell, bilobed, appearance of fat density in the atrial septum, sparing the fossa ovale. It spares the fossa ovalis, creating a dumbbell appearance. When it doesn't spare it, think lipoma. It's associated with being fat and old. As a point of trivia, it can cause supraventricular arrhythmia, although usually does nothing. Additional even more high-yield trivia is that it can be hot on PET because it's often made of brown fat. 372. Sec 110N2 Coronaries. Questions regarding the coronaries will likely come in two flavors: normal, which will be mostly vocab, and abnormal, which will only have one or two pathologies. Normal. There are three coronary cusps, right, left, and non-coronary, posterior. The left main comes off the left cusp, the right main comes off the right cusp. Left main. Right main. /circflex, LCX, LAD. Acute marginal AV node branch. Obtuse marginals supply the lateral margin. Septal branches. Diagonals Ladford. Posterior descending artery, PDA, 65% to 80%, asterisk the other 20% have the PDA supplied by the left coronary. With regard to what perfuses what, the following are high-yield factoids. RCA perfuses SAN node 60%. 60% RCA perfuses AV node 90%. 373. Typical vascular perfusion territories are cord-like tendons called chordae tendinae. The papillary muscles insert into the lateral and posterior walls as well as the apex of the left ventricle, not the septum, as is the case on the right. Echogenic focus in left ventricle, relatively common sonographic observation seen on prenatal ultrasound. It is a calcified papillary muscle that usually goes away by the third trimester. So who gives a shit? Well, they are associated with an increased incidence of Downs, 13%. Don't get it twisted, having one means nothing other than you should look for other signs of Downs, most of the time it's normal. Echogenic focus in left ventricle. Lipomatous hypertrophy of the intra-atrial septum. This has a very classic look of a dumbbell, bilobed, appearance of fat density in the atrial septum, sparing the fossa ovale. It spares the fossa ovalis, creating a dumbbell appearance. When it doesn't spare it, think lipoma. It's associated with being fat and old. As a point of trivia, it can cause supraventricular arrhythmia, although usually does nothing. Additional even more high-yield trivia is that it can be hot on PET because it's often made of brown fat. 372. Sec 110N2 Coronaries. Questions regarding the coronaries will likely come in two flavors: normal, which will be mostly vocab, and abnormal, which will only have one or two pathologies. Normal. There are three coronary cusps, right, left, and non-coronary, posterior. The left main comes off the left cusp, the right main comes off the right cusp. Left main. Right main. /circumflex, LCX, LAD. Acute marginal AV node branch. Obtuse marginals supply the lateral margin. Septal branches. Diagonals Ladford. Posterior descending artery, PDA, 65% to 80%, asterisk the other 20% have the PDA supplied by the left coronary. With regard to what perfuses what, the following are high-yield factoids. RCA perfuses cyanotic. This displays the LV and LA, two chambers. This is good for a few things: 1. Wattle motion I global LV function, and 2. Mitra. Valve issues, regurg etc. The anatomy trick would be to have you ID the coronary sinus on this view. The three-chamber. Some people will call this an apical long-axis view. The major plus to this view is that it lets you see the left ventricular outflow tract, LVO, and is ideal for look at flow through this area, i.e. aortic regurg. A way a question could be asked is what view is best for aortic regurg. Stenosis, or which of the following views, and make you pick out the picture of the three-chamber. Or just straight ask you, what is this view? RV. Four-chamber long axis. LVO. Coronary sinus. Dominance. Coronary dominance is determined by what vessel gives rise to the posterior descending artery and posterior left ventricular branches. Most are right 85%. You can be codominant if the posterior descending artery arises from the right coronary artery and the posterior left ventricular branches arise from the left circumflex coronary artery. 374. Not normal, anomalies of the origin, course, and termination. Malignant origin, most common and most serious, LCA from the right coronary sinus, coursing between the aorta and pulmonary artery. This guy can get compressed and cause sudden cardiac death. Anomalous right off the left cusp - repair if symptomatic. Anomalous left off the right cusp always repair. Normal anatomy. RCA. Intra-Atrial LCA, the bad one. Alcapa, anomalous left coronary from the pulmonary artery. There are two types: A. Infantile type, they die early, and B. Adult, still at risk of sudden death. The multiple choice question is going to be Steele syndrome, which describes a reversal of flow in the LCA as pressure decreases in the pulmonary circulation. Myocardial bridging. This is an intramyocardial course of a coronary artery, usually the LAD. The finding may cause symptoms as the diameter decreases with systole, or may cause an issue for CAP planning. This can be a source of ischemia. Coronary artery aneurysm. By definition, this is a vessel with a diameter greater than L.5x the normal lumen. Most common cause is atherosclerosis. Most common cause in children is Kawasaki, spontaneously resolves in 50%. They can occur from lots of other vasculitids as well. Last important cause is Echogenic, cardiac cath. Coronary fistula, defined as a connection between a coronary artery and cardiac chamber or great vessels. It's usually the RCA, with drainage into the right cardiac chambers. They are associated result in coronary aneurysm. If you see big crazy dilation of the coronaries, think about this. 375. Coronary CT. Who is the ideal patient to get a coronary CT? There are two main groups of people getting these. L. Low risk or atypical chest pain patients. A negative coronary CT will help stop a stress test or cath from occurring. Why do a procedure with risks on someone with GERD? 2. Suspected aberrant coronary anatomy. What is the ideal LIAT rate? To reduce motion-related artifacts, a slow heart rate is preferred. Most books will tell you under 60 beats per min. Beta blockers are used to lower the heart rate to achieve this ideal rate. Are there contraindications 11s to beta blockers? Yup. Patients with severe asthma, heart block, acute chest pain, or recent snorting of cocaine should not be given a beta blocker. Are all heart blocks contraindications to beta blockers? Second and third degree are contraindications. A first degree block is not. What if I can't give the beta blocker? Can he still have the scan? Yes, you just can't use a prospective gating technique. You'll have to use retrospective gating. What is the difference between prospective and retrospective gating? Pro./pective, times step and shoot, our interval asterisk data acquisition triggered by our wave pro. There is reduced radiation B/C. The scanner isn't on the whole time con, no functional imaging trivia, always axial, not helical. Retrospective, scans the whole time, then back calculates pro, can do functional imaging con, higher radiation, use of low pitch increases dose, trivia. This is helical. Other than beta blockers, are any other drugs given for coronary CT? Yup. Nitroglycerin is given to dilate the coronaries, so you can see them better. Are there contraindications to nitroglycerin 11E? Yup. Hypertension, SBP. 376. Section 3 Valves. Velocity-encoded cinemistor imaging, VENC, also known as velocity mapping or phase contrast imaging, is a technique for quantifying the velocity of flowing blood. Aortic stenosis. This may be congenital, bicuspid, or acquired, degenerative or rheumatic heart. Increased afterload can lead to concentric LV hypertrophy. Peak velocity through the valve can be used to grade the severity. Velocity-encoded cinemistor imaging, VENC, which also answers to the name velocity mapping or phase contrast imaging, is an MRL technique for quantifying the velocity of flowing blood, if anyone would happen to ask. Dilation of ascending aorta is due to jet phenomenon related to a stenotic valve. Comes in three flavors, A. Valvular, B. Subvalvular, C. And supravalvular. Valvular is the most common, 90%. When I say supravalvular aortic stenosis, you say Williams syndrome. Leon, I say bicuspid aortic valve, and coarctation, you say Turner's syndrome. Bicuspid aortic valve. This is very common. Some sources will say nearly 2% of the general population. As a result, it becomes the source of significant fuckery with regard to one particular multiple choice question: what is the most common congenital heart disease? The answer is probably bicuspid aortic valve, but because it's often asymptomatic and not a problem till later in life when it gets stenotic and causes syncope, I think it messes with people's math or doesn't get thought of by the question writer. How do you handle this question? Well, if they list bicuspid aortic valve, then you have to pick it. If they don't list it, then the answer is VSD. Trivia to know. Bicuspid aortic valve, even in absence of stenosis, is independent risk factor for aortic aneurysm. Association with cystic medial necrosis, CMN. Association with Turner's syndrome, and coarctation. Association with polycystic kidney disease. Aortic regurgitation, seen with bicuspid aortic valves, bacterial endocarditis, Marfan's, aortic root dilation from HTN, and aortic dissection. How rapid the regurgitation onsets determines the hemodynamic impact. Acute onset doesn't allow for adaptation. Mitral stenosis, rheumatic heart disease is the most common cause. The case could be shown as ACXR with left atrial enlargement, double density sign, splaying of the carina, posterior esophageal displacement. 377. Mitral regurgitation. The most common acute causes are endocarditis or papillary muscle caudal rupture post-ME. Step 1 question was Austin Flint murmur. The chronic causes can be primary, myxomatous degeneration, or secondary, dilated cardiomyopathy leading to mitral annular dilation. Remember, the isolated right upper lobe pulmonary edema is associated with mitral regurgitation. Pulmonary stenosis, just like in the aortic valve, comes in 3 flavors: A. Valvular, B. Subvalvular, C. And supravalvular. Valvular is the most common, and can lead to ventricular hypertrophy. Associated with Noonan syndrome, male version of Turner's. Peripheral pulmonary stenosis is seen with Alagille syndrome, kids with absent bile ducts. Williams can give you supravalvular aortic stenosis, and pulmonic. I. Williams syndrome. Noonan syndrome, Supravalvular stenosis. Valvular stenosis. Regurgitation. The most common situation for this is congenital valve disease after valve surgery. The classic scenario is actually TOF patient who has been repaired. Tricuspid regurgitation, most common form of tricuspid disease, due to the relatively weak annulus, compared to the mitral. May occur in the setting of endocarditis, for drug use, or carcinoid syndrome. Serotonin degrades the valve. The most common cause in adults is pulmonary arterial hypertension. A testable pearl is that TR causes RV dilation, not RV hypertrophy. Subvalvular stenosis. Pulmonary stenosis syndromes. Gamesmanship. Rheumatic heart disease most commonly involves the mitral and aortic valves. Anytime there is multivalve disease, think rheumatic fever. Step I trivia. Rheumatic heart disease is an immune-modulated response to group A beta hemolytic strep. Epstein anomaly, seen in children whose moms used lithium, most cases are actually sporadic. The tricuspid valve is hyperplastic and the posterior leaf is displaced apically, downward. The result is enlarged RA, decreased RV, atrialized, and tricuspid regurgitation. They have the massive box-shaped heart on CXR. Tricuspid ataxia, congenital anomaly that occurs with RV hypoplasia. Almost always has an ASD or PFO. Recognized association with asplenia. Can have a right arch, although you should think truncus and TOF first. As a point of confusing trivia, tricuspid ataxia usually has pulmonary stenosis and therefore will have decreased vascularity. If no PS is present, there will be increased vascularity. Carcinoid syndrome. This can result in valvular disease, but only after the tumor has met D to the liver. The serotonin actually degrades heart valves, typically both the tricuspid and pulmonic valves. Left-sided valvular disease is super rare since the lungs degrade the vasoactive substances. When you see left-sided disease you should think of 2 scenarios: 1. Primary bronchial carcinoid, or 2. Right to left shunts. 378. Sec 110N4 great vessels. The most common variant in branching is the bovine arch, in which the brachiocephalic artery and left common carotid artery arise from a common origin. The terminology right arch I left arch is described based on the aortic arch's relationship to the trachea. When I say right arch with mirror branching, you say congenital heart. Bovine arch, or bovizel per Snoop Dogg. Left arch, normal, right arch. There are 5 types of right arches, but only 2 are worth knowing: aberrant left, and mirror branching. The trick to tell these 2 apart is to look for the origin of the left subclavian. Originating from the front of the arch equals mirror image. Asterisk, this is the bad one, L.Ots of congenital heart. Originating from the back of the arch equals aberrant left subclavian. 379. Right arch with aberrant left subclavian. The last branch is the left aberrant subclavian artery. This is a vascular ring because the ligamentum arteriosum, on the left, completes the ring encircling the trachea. Right arch with mirror branching. Although these are often asymptomatic, they are strongly associated with congenital heart disease. Most commonly they are associated with TOF. However, they are most closely associated with truncus. Obviously, this tricky wording lends itself nicely to a trick question. If there is a mirror image right arch, then 90% will have TOF, 6% trunk 1. If the person has truncus, then they have a mirror image right arch 33%, I of 25%. Left arch aberrant right subclavian, the most common arch anomaly. Although it is usually asymptomatic, it can sometimes be associated with dysphagia luceraria, as the RSCA passes posterior to the esophagus. The last branch is the right aberrant subclavian artery. The origin of the RSCA may be dilated equals diverticulum of Comrill. Double aortic arch, the most common vascular ring. As a point of trivia, symptoms may begin at birth and include tracheal compression and forward/ or difficulty swallowing. The right arch is larger and higher, and the left arch is smaller and lower. Arches are posterior to the esophagus and anterior to the trachea, encircling them both. 380. Subclavian steal syndrome / phenomenon. So there is a syndrome and there is a phenomenon. The distinction between the two makes for an excellent distractor. SS phenomenon, stenosis and forward/ or occlusion of the proximal subclavian with retrograde flow in the ipsilateral vertebral artery. SS syndrome, stenosis and forward/ or occlusion of the proximal subclavian artery with retrograde flow in the ipsilateral vertebral artery and associated cerebral ischemic symptoms. LVERT. RSCA occlusion proximal to the vertebral in the subclavian can result in retrograde stolen flow from the vertebral artery. If the level of stenosis and forward/ or occlusion is proximal to the vertebral artery, reversal of flow in the vertebral artery can occur, resulting in the theft of blood from the posterior circulation. When the upper limb is exercised, blood is diverted away from the brain to the arm. Cerebral symptoms, dizziness, syncope, etc., depend on the integrity of collateral intracranial flow, PCOMs. Subclavian steal is almost always caused by atherosclerosis, 98%, but other very testable causes include Takyasu arteritis, radiation, Productor aortic coarctation, and Blalock-Taussig shunt. In an adult they will show atherosclerosis. If they show a teenager 20-year-old, it's gonna be Takyasu. Casebooks love to show this as an angiogram, and I think that's the most likely way the test will show it. They could also show ACTA or MIA, although I'd say that is less likely. Aortic aneurysm and vasculitis will be discussed in the vascular chapter. 381. Section 5. Congenital heart. An extremely high-yield and confusing topic which dinosaur radiologists love to ask questions about on CXR. Obviously, this is stupid since you could only add confusion to a bad situation by suggesting a diagnosis on CXR instead of waiting for echo or MI. Having said that, the next section will attempt to provide a methodology for single answers on CXR cases. My thoughts on multiple choice questions regarding congenital heart is that they will come in 3 flavors: A. Und mini, B. Differentials with crappy distractors, and C. Associations I trivia. Und minis I differentials. There are a few congenital heart cases that are und minis, or easily solvable, most are differential cases. Bottom line is that if they want a single answer they will have to show you either an und mini or a differential case, with crappy distractors. With regard to straight-up und minis, I think the usual characters that most third-year medical students memorize are fair game. Scimitar sword, PAPV with hypoplasia. An extremely high-yield and confusing topic which differential cases. Und minis I differentials. There are a few congenital heart cases that are und minis, or easily solvable, most are differential cases. Bottom line is that if they want a single answer they will have to show you either an und mini or a differential case, with crappy distractors. Und minis I differentials. There are a few congenital heart cases that are und minis, or easily solvable, most are differential cases. Bottom line is that if they want a single answer they will have to show you either an und mini or a differential case, with crappy distractors. With regard to straight-up und minis, I think the usual characters that most third-year medical students memorize are fair game. Scimitar sword, PAPV with hypoplasia. 382. The easily solvable ones will be shown as a right arch with the associations of truncus, more closely associated, and TOF, more common overall. Or, they will show you the big box heart and want Epstein's, which is an und mini. Another classic trick with regard to the big box heart is non-cardiac causes of high output failure, infantile hemangioendothelioma and vein of Galen malformation. The remaining cyanotic syndromes basically look the same, so the questions must be either A. Crappy distractors, none of the others are cyanotic, etc., or B. Trivia, which is more likely. I cyanotic I. Asterisk they have to tell you this, if they want a single answer. Not cyanotic. Not cyanotic. CHF in newborn. TAPV, ultracardiac type ill. Infantile, preductal, poplar. Trivia and associations. VSD, the most common congenital heart disease. There are several types with membranous, just below the aortic valve, being the most common, 70%. Outlet subtypes, infundibulum, must be repaired as the right coronary cusp prolapses into the defect. On CXR we are very specific, big heart increased vasculature, small aortic knob. They could ask or try and show splaying of the carina, from big left atrium. About 70% of the small ones close spontaneously. PDA. The PDA normally closes around 24 hours after birth, functionally, and anatomically around 1 month. A PDA should make you say 3 things: 1. Prematurity, 2. Maternal rubella, 3. Cyanotic heart disease. CXR is specific, big heart, increased pulmonary vasculature, large aortic arch ductus bump. You can close it or keep it open with meds. ASD, several types with the secundum being the most common, 50 to 70%. The larger subtype is the primum, results from an endocardial cushion defect, is more likely to be symptomatic. Only secundums may close without treatment, primum, AV canal, sinus venosus will not. Primums are not amendable to device closure because of proximity to AV valve tissue. On CXR if it's small it will show nothing, if it's large it will be supinaspecific. Big heart, increased vasculature, and small aortic knob. It's more common in female. When I say hand forward/thumb defects and ASD, you say Holt Oram. When I say ostium primum ASD, or endocardial cushion defect, you say Downs. When I say sinus venosus ASD, you say PAPV. 384. AV canal, also referred to as an endocardial cushion defect. They happen secondary to a deficient development of a portion of the atrial septum, a portion of the interventricular septum, and the AV valves. Strong association with Downs. You can't use closure devices on these dudes either. Surgical approach and management is complex and beyond the scope of this text. Trivia: of all the congenital heart stuff with Downs patients, AV canal is the most common. Euroofed coronary sinus. This is a rare ASD which occurs secondary to a fenestrated, as in the cartoon, or totally unroofed coronary sinus. The most important clinical is that you can get paradoxical emboli and chronic right heart volume overload. Trivia: strong association with a persistent left SVC. PAPV, partial anomalous pulmonary venous return, is defined as 1 or more of the 4 pulmonary veins draining into the right atrium. It is often of mild or no physiologic consequence. It is often associated with ASDs, secundum and sinus venosus types. When I say right-sided PAPV, you say sinus venosus ASD. ORUL, SVC association with sinus venosus type ASD. When I say right-sided PAPV plus pulmonary hypoplasia, you say Lyomatous syndrome. Sinus venosus ASD. 385. TAPV, a cyanotic heart disease characterized by all of the pulmonary venous system draining to the right side of the heart. A large PFO or less commonly ASD is required for survival. This is a high yield and testable point. There are 3 types, but only 2 are likely to be tested. Cardiac type 2 just doesn't have good testable features. All 3 types will cause increased pulmonary vasculature, but type 3 is famous for a full-on pulmonary edema look in the newborn. Type 1, supracardiac. O most common type O veins drain above the heart, gives a snowman appearance. Type 2, cardiac O second most common type 3, Ultracardiac O veins drain below the diaphragm, hepatic veins or IVC, O obstruction on the way back through diaphragm is common and causes a full-on pulmonary edema look. Key points on TAPV. Supracardiac type equals snowman. Ultracardiac type equals pulmonary edema in newborn large PFO, or ASD, needed to survive asplenia. 50% of asplenia patients have congenital heart issues. Of those, nearly 100% include TAPV. 85% have additional endocardial cushion defects. 386. Transposition. This is the most common cause of cyanosis during the first 24 hours. It is seen most commonly in infants of diabetic mothers. The basic idea is that aorta arises from the right ventricle and the pulmonary trunk from the left ventricle. Ventricular atrial discordance. Which one is the right ventricle? You have to find the moderator band that defines the RV. Just like TAPV, survival depends on an ASD, VSD, or PDA, most commonly VSD. There are 2 flavors, D and L. The D type only has a PDA connecting the 2 systems, whereas the L type is lucky enough to be compatible with life. D transposition, classic radiographic appearance is the egg on a string. String occurs from discordance between the ventricles and the vessels. The intra-atrial baffle, mustard or Senning procedure, is performed to fix them. L transposition, the L type is lucky enough to be congenitally corrected. This occurs from a double discordance where the atrium hooks up with the wrong ventricle and the ventricle hooks up with the wrong vessels. In zero transposition, the ductus may be the only connection between the 2 systems, which would otherwise be separate. Tetralogy of Fallot, TOF. The most common cyanotic heart disease. Describes 4 major findings. 1. VSD. 2. OVO obstruction often from valvular obstruction. 3. Overriding aorta. 4. RV hypertrophy, develops after birth. The degree of severity in symptoms is related to how bad the OVO obstruction is. If it's mild, you might even have a pink tet that presents in early adulthood. This is called a pentalogy of Fallot if there is an ASD. Very likely to have a right arch. Surgically, it's usually fixed with primary repair. The various shunt procedures, Blalock Torsieg being the most famous, is only done if the kid is inoperable or to bridge until primary repair. Trivia: the most common complication following surgery is pulmonary regurgitation. Truncus arteriosus, cyanotic anomaly where there is a single trunk supplying both the pulmonary and systemic circulation, not of a separate aorta and a pulmonary trunk. It almost always has a VSD, and is closely associated with right arch. Associated with catch-22 genetics, Di-George syndrome. Coarctation, narrowing of the aortic lumen. This comes in two flavors: 1, infantile, preductal. These guys can have pulmonary edema. 2, adult, ductal. Things to know. Truncus arteriosus, cyanotic anomaly where there is a single trunk supplying both the pulmonary and systemic circulation, not of a separate aorta and a pulmonary trunk. It almost always has a VSD, and is closely associated with right arch. Associated with catch-22 genetics, Di-George syndrome. Coarctation, narrowing of the aortic lumen. This comes in two flavors: 1, infantile, preductal. These guys can have pulmonary edema. 2, adult, ductal. Things to know. Strong association with Turner's syndrome, 15 to 20%. Bicuspid aortic valve is the most common associated defect, 80%. They have more berry aneurysms. Figure 3 sign, appearance of CXR. Rib notching, most often involves 4th, 81H ribs. It does not involve the ST and second because those are fed by the costocervical trunk. Hyperplastic left heart, left ventricle and aorta are hyperplastic. They present with pulmonary edema. Must have an ASD or large PFO. They also typically have a large PDA to put blood in their arch. Strongly associated with aortic coarctation and endocardial fibroblastosis. 388. Cor triatriatum sinistrum. This is a very rare situation where you have an abnormal pulmonary vein draining into the left atrium, sinistrum meaning left, with an unnecessary fibromuscular membrane that causes a subdivision of the left atrium. This creates the appearance of a triatrium heart. This can be a cause of unexplained pulmonary hypertension in the PED setting. Basically it acts like mitral stenosis, and can cause pulmonary edema. The outcomes are often bad, fatal within 2 years, depending on surgical intervention and associated badness. Cor triatriatum sinistrum. 389. Section 6. Ischemic heart. Imaging regarding ischemic heart disease is going to fall into two modalities, cardiac MR and nuclear. Cardiac MI currently offers the most complete evaluation of ischemic heart disease. Disease. Myocardial infarction typically is initiated by rupture of an unstable coronary atherosclerotic plaque, leading to abrupt arterial occlusion. The wavefront of necrosis always starts subendocardial and progresses to the subclavian. The ischemic necrosis will affect not just the myocardium but also blood vessels. The destruction of small capillaries will not allow contrast to the area of injury. TIS is termed microvascular obstruction and manifests as islands of dark signal in a notion of delayed enhancement. The presence of microvascular obstruction is an independent predictor of death and adverse LV remodeling. Testable vocab. Stunned myocardium, after an acute injury, ischemia or reperfusion injury. Dysfunction of myocardium persists even after restoration of blood flow, can last days to weeks. A perfusion study will be normal, but the contractility is crap. Hibernating myocardium, this is a more chronic process, and the result of severe CAD causing chronic hypoperfusion. You will have areas of decreased perfusion and decreased contractility even when resting. Don't get it twisted, this is not an infarct. On a FDG PET, this tissue will take up tracer more intensely than normal myocardium, and will also demonstrate redistribution of thallium. This is reversible with revascularization. SCA, this is dead myocardium. It will not squeeze normally, so you'll have abnormal wall motion. It's not a zombie. It will not come back to life with revascularization. Stunned hibernating J infarcti SCA. Wall motion, abnormal wall motion. Motion abnormal wall motion abnorm 1L _ normal perfusion.
नहीं है बस में ये बात ले
Perfusion, thallium. (390). Delayed imaging. It works for two reasons. 1. Increased volume of contrast material distribution in acute myocardial infarction and inflammatory conditions. 2. Scarred myocardium washes out more slowly. It is done using an inversion recovery technique to null normal myocardium, followed by a gradient echo. TL shortening from the GD looks bright. Bright is dead. Why stress imaging is done? Because coronary arteries can autoregulate. A stenosis of 85% can be asymptomatic in a resting state. So demand is increased by exercise or drugs, making a 45% stenosis significant. An inotropic stress agent, dobutamine, is used for wall motion, and a vasodilator, adenosine, is used for perfusion analysis. MI in acute MI. Cardiac MI can be done in the first 24 hours post-MI, if the patient is stable. Late gadolinium enhancement will reflect size and distribution of necrosis. Characteristic pattern is a zone of enhancement that extends from the subendocardium toward the epicardium in a vascular distribution. Microvascular obstruction will present as islands of dark signal in the enhanced tissue, as described above, and this represents an acute and subacute finding. Microvascular obstruction is not seen in chronic disease as these areas will all turn to scar eventually. In the acute setting, 1 week, injured myocardium will have increased T2 signal, which can be used to estimate the area at risk. T2 Bri, enhanced equals salvageable tissue. Acute vs chronic MI. Both have delayed enhancement. If the infarct was transmural and chronic, you may have thinned myocardium. Acute will have normal thickness, chronic can too but shouldn't for the purposes of MC tests. T2 signal from edema may be increased in the acute setting. You won't see microvascular obstruction in chronic. Acute is T2 bright, edema, chronic is T2 dark, scar. Low do you diagnose myocardial LF, with contrast enhanced Mr. I. Delayed enhancement follows a vascular distribution. 2. The enhancement extends from the condycardium to the epicardium. 391. Microvascular obstruction, islands of dark tissue in an ocean of late GD enhancement. These indicate microvascular obliteration in the setting of an acute infarct. The GD is unable to get infarct. The GD is unable to get to these regions even after the restoration of epicardial blood flow. Microvascular obstruction is a poor prognostic finding, associated with lack of functional recovery. Key point, it's not seen in chronic infarct. Trivia, microvascular obstruction is best seen on FRST pass imaging, 25 seconds. Ventricular aneurysm, this is rare, 5%, but can occur as the result of MI. The question is always true vs false. True, mouth is wider than body. Myocardium is intact. Intact. Usually anterior lateral wall. False, mouth is narrow compared to body. Myocardium is not intact, pericardia. Adhesions contain the rupture. Usually posterior lateral wall. High risk of rupture. False aneurysms are usually posterior lateral, true aneurysms are usually anterior lateral. Viability, you can grade this based on % of transmural thickness involved in the infarct. 25 to 50% may improve. 50 to 100%. 50 to 100%. 50 to 100%, unlikely to recover function. What is the timing on the bad CKL and MI? Dressler syndrome 4 to 6 weeks I. U, LR_U_CH_2 to 7 days. Underscore JI ventricle pseudoaneurysm 3 to 7 days T ventricular aneurysm months, requires remodeling and thinning. Myocardial rupture underscore, idineus, 50% of the time, underscore.